Um, so I'm Enrique, and over the next few minutes, really, I just wanted to give you some tips and ideas, but also to learn about what kind of problems you already have, where you could be using implementation techniques, behavioral approaches, and kind of work together to try to solve the problems. So really, really happy if you want to stop me, if you want to say that I'm wrong, because I'm sure I will be wrong. If you want to disagree, if you actually disagree, just sort of mention. So we have started at 1:45, and I'll really stick to time. So first of all, can I ask who is an IPC nurse or an antimicrobial stewardship nurse? Who's a nurse working? Okay, we've got kind of the majority of people. Great. Anybody else who's not a nurse? Doctor, pharmacist, psychologist, dietitian. Okay, super. I think that overall, I hope you agree that it's a fantastic time to be working in IPC. I think that we have never been in such a sort of wonderful and positive la-la land position, isn't it? Because of we have got core competencies in place at a European level where we are all kind of be looking to be learning and working in the same or a similar way with other colleagues. And we have got what I call this European harmony about infection prevention and control. So we're learning from each other. Each country is teaching each other. We have got a common sort of problem in infection prevention and control, or we have got many problems that are common to all of us. So we're learning from each other. We're teaching each other, and we have got more and more documents and guidelines. So it's wonderful. And when I think about nurses in particular, you can see how we have got connections everywhere. And we have got connections with, the guys and the people in TB and HIV, which is another sort of wonderful field. And we can link up with antimicrobial stewardship. We can sort of work with patient safety, or pretend that we are patient safety, or consider that we are patient safety. We need to be really good with the media, the newspapers, the television, radio, to talk to our citizens, occupational health, the community. IPC is a really exciting place to be working, because we have got those natural connections. So at least I think that those are natural connections for IPC. And as some other people elect me are saying that we could be taking over antimicrobial stewardship, that close connection between IPC and AMS. And I think that nurses and many other workers, but nurses in particular, not just in the European setting, but particularly in other settings in low-middle income countries, we could be really not taking over is not the right way of saying, but we can sort of lead antimicrobial stewardship. So all these are it's a little description about how exciting it is. But the first sort of strong, powerful idea related to implementation that I wanted to give you, and perhaps learn from you, is that everything that we do in hospitals, in GP practices, in the community care, the way that we look after people, is not a product that's created in isolation, isn't it? A hospital really is a cosmos, is a universe of people working together. And what happens in the end, care, is just a product of all those interconnected networks. And you as a nurse and you as an IPC professional and practitioner, you really can and should cut across all those networks. And as has been said before, connect them, isn't it? You are the glue, you could be the glue between those different networks and groups of people. And what I mean about networks is not just professional networks, so doctors, pharmacies, carers, other professionals, but thinking about different settings, so hospital and community, you are talking to them, they are talking to you. You have got the power, you are in a position to influence what happens in those professional groups and networks and settings. Is that something that you agree with, that is it the fundamental to who we are and what we do and what you do? Yeah, everybody's saying yes, absolutely. But I think that if we sort of believe that we are connecting, that we are connectors, and before Walter has mentioned the knowledge brokering thing, not only we are connecting people, but we are passing and moving and transferring knowledge from one network to the other, from one professional group to the other, from the patients to the clinicians, from the clinicians to the patients. So thinking about transformation and implementation, if we have to convince professional groups about this new intervention that we're going to launch or that we're preparing to launch, that convincing is based on trust and knowledge about the person, about the people. So as implementers, even if you're not thinking that you are being part of this implementation chain, you have got probably one of the most fundamental roles in implementation. So that would be my first really powerful idea, that care happens because of loads of people are working together, loads of systems are working together, and you can and must cut across them. And of course, that's important because IPC is not just like a linear process. It's not A doesn't really lead to B, or we've got the guidelines and therefore the clinicians will sort of read them and perform the behaviors that they are written in the guidelines. That just doesn't happen. And we know that this is really the reality of not just IPC care or practice, but essentially human practice. This is our world, isn't it? It's messy, we go back and forth, we come back on our steps, and that happens in IPC as well and in hospitals, doesn't it? That happens in implementation, in fact. It's just that we call it sort of like, PDSA or some sort of like a fancy label. But essentially, it's a spiral of practice. But it's sort of messy and it's not linear. And we need to be comfortable and confident that that's how the process happens. And of course, I think that to sort of solve the problem of that messiness up until now, and as this morning was mentioned, I think that we've relied on technical solutions to resolve that issue. And what we call technical solutions, or what I call technical solutions, is sort of education, guidelines, policies. And we know that alone those solutions are not really enough, isn't it? You agree that the documents, the policies and the guidelines are not really what we need, or are not really what we just need? Yeah? No? Yeah? Yeah, cool. And we have got evidence about it, for example, in prescribing, when we have developed educational packages for prescribers, and then we ask them, they tell us, hang on, now I may have more knowledge, but I still have got gaps in my skills, in my confidence, in my self-efficacy that was mentioned before. And again, you've got plenty of data about that. So that's education is not really enough. And these are my neighbors from Barcelona. And the issue about guidelines as well is that the guidelines, the documents are transformed by the people who use them, isn't it? We believe that the guidelines are clear enough, but they're not. People will interpret them. What does this actually mean? And even if we think that they mean the same thing for all of us, people will use the guidelines in a slightly different way or in a very different way. So again, that kind of creates its own body of knowledge that has to be integrated with each other's body of knowledge. So the document, even if it looks very clear and a unique document, it isn't. There are as many guidelines as people using them. So we cannot, again, rely on them. So all these sort of slides, they're just there to sort of show you how we've kind of come to the behavioral perspectives in IPC. So I think that our group was quite innovative a few years ago, reviewing the studies that had taken place with that approach, looking at the behavior rather than at the classic knowledge education to improve IPCs. And it was very interesting. Between 1999 and 2011, there were only 21 studies had been identified. But now if you look at between 2012 and now, the explosion of the literature is quite dramatic, quite interesting, but it's quite dramatic. And that's just tells us about that, right? So from the point of view of IPC, we need to be confident and comfortable with this aspect of practice because it's truly shaping what we do and what we should do. So I definitely urge all of you clinicians and practitioners to sort of bear this in mind. This aspect of our practice is not going to go away, and as we see, is molding what we do. And at least in the UK, and this is Sally Davies, the Chief Medical Officer, the language used is very interesting. Like hospitals will need to learn a new language. And that is quite a powerful message, isn't it? Like the top doctor in the country is saying to every clinician, every organization, you need to learn a new language of care, language of practice, to strengthen infection prevention and control, using new methods of organizational and behavioral change. I probably don't agree with it to reinforce policy implementation. We have to use those new methods of organizational and behavioral change because they're good in themselves, not to reinforce something else. But that is a sort of personal point, and of course I wouldn't argue with the chief medical officer of my country, but I think the language is so powerful, it's so clear what we've been told. We have to be excellent at this new way of working. How do these approaches work for you in France? Traditional approaches where experts like all of you will tell non-experts to do something. How well, I'm Spanish, so I know how well these approaches work in Spain. They work very well. And how do they work for you here? If you feel you can say that they don't work very well, how do they work for you here? Cool. So essentially, Gabriel is saying they don't work very well, isn't it?
Telling people what to say, what to do in terms of hygiene, and just staying. No, I was just saying on behalf, I think most of the people here, that going to a ward and saying, go wash your hand, here is the 5 moments of WHO, do that, and I'm coming back in 1 month and we'll see if you are doing it. It's not the right way to do. And I think IPC units and IPC professionals are, most of them are positioned at a high level with a sort of top-down, like you put on your slide, rather than speaking like an equivalent. Yep. Maybe it's a strong, it's a strong way of telling things, but it's more or less this, I think. I don't know if you have another point of view. Pierre.
Yeah.
The usual answer is, yes, we know, but we don't.
Okay. And that is a very human answer, in a way, isn't it? Because we're not appealing for people's knowledge. We're appealing to people's behaviors, but then we're giving them a mixed message, isn't it? So I find very interesting that this sign is actually in the toilets of many places in the UK, but you find this sign literally by the door, not where you should be performing the task. And it's a classic example of hand hygiene, isn't it? Now do something not in the right place, and when you've got more important things to do, which is leaving the place where you've just sort of been and used the toilet. So anyway, but it's a classic example of the traditional approaches, top-down, expert-driven education. This approach doesn't have us. It's got them and us, for example. We are not working together when we use this approach. That is important to linking up with what Gabriel said, isn't it, about peers. The top-down approach is dead because we're all working together, or we should be working together. And again, this is a typical example of us and them, and this could be in infection prevention and control. Someone very expert, sort of like a road engineer or an architect, has designed how the urbanism of this place. So that's the road on the left. This is what the human is expected to use on the left. But humans are really, really always striving for efficiency. And efficiency meaning they need to achieve something with the least effort. And that human is actually teaching us the most efficient way of going from A at the bottom to B. Now with the traditional approach, and it's interesting because that line that's created in English is a path of desire, or a desire path. That's how that little road is called. And they're fascinating to see. When you leave the building and you walk around and have a look at the park and you see these everywhere. And those are messages that the users are leaving there for us to pick up or not. They're telling us, that's your way, And that's the way. And you know, again, when things fail, when programs and interventions fail, the traditional approach will be, hang on, what's wrong with this team? Why are they not washing their hands? Why are they not looking at the catheters? Why are they not changing the prescription? That's us saying what's wrong with them. Why don't they understand what we tell them to do? It is so easy. Our road is better, is wider, is cleaner, is nicer. And the humans are not saying anything. They're just walking the way. So think about what interventions you've introduced, where you had designed them, and then the humans, the users, were telling you how the intervention should have been and should be. Have you got many examples of something like that? Yeah? No? Yeah? Yeah? You, Gabriel?
When you look at the traffic flow in the operating theater, it's pretty obvious, you know.
Yeah.
So when you have 5 doors, people will use the 5 doors and probably the larger one because it will be easy to get in with it. But if you've got only one door, they will go through it because there is no other choice, and it will potentially have an impact on the air contamination during surgery. Yeah. So it's like you. So I would summarize your picture like an ergonomic stuff.
Yeah, I mean the desire path is the most efficient point between point A and B, and I do think that, you know, I'm surprised that they're not aligned. But you know, humans are fascinating. I just love sort of working in this area because again, we get messages from the users. We're just not very good at picking them, or understanding them, or paying attention to them. So as I said, you know, the right behavioral lens that you could apply to your interventions is not what's wrong with them. Why don't they do what we tell them to do? Is what is it about our intervention that is not working? What is it about our perspective? What is it about our preconceptions that they're not being useful to solve the problem? What do we need to offer the users to offset behavioral cost? If people have to do something, why would they do it? If people have to wash their hands every time the right way at the right time, why would they do it? Do you know why would they do it? Or do you assume that it's because they want to be good professionals? Or you assume that it's because they want to give the best possible care to their patients? Is that what you think? Or no? No, okay. But again, you know, we need to know our audience. And again, what will make our behavior more attractive than the competition? The competition is all the other 2,000 or 3,000 or 4,000 behaviors that practitioners and doctors and nurses, pharmacists have to perform every day during the clinical practice. You know, why will they choose your behavior, our behavior, compared with the others? Why will they spend time looking at the prescription chart rather than washing their hands, or reading up about innovations, or talking to people and sort of creating a team bond? Why would they choose one over the other? Now, can I ask you to vote? You know, do you think that this behavior is a rational thing? And I'm a child of the 70s, so of course these things have to come up. A rational thing like Mr. Spock, or an emotional aspect like Captain Kirk? What do you think?
Donc c'est ouvert au vote à partir de maintenant. Okay. The answer.
Okay, hang on. Before we go a third, is this working really, or this is... So a third of people, again, you know, this is fascinating because we would have assumed that there could be a consensus about behavior, isn't it? But again, if you're thinking about applying behavioral interventions, and it may be that users or people see them in a more rational or more emotional way, then we may have a little bit of a clash of cultures there. But can I ask someone who voted for the emotional option to say why they did that? I mean, you know, behaviors, are they an emotional thing, really? Yeah? Or someone who voted for the rational sort of aspect, could they say why they voted, or could they give an example?
Bah, pour faire au plus court, au plus rapide, au plus feignant, quoi. Oui,
So emotional is
C'est donc pour aller au plus vite, plus rapide, et puis en étant feignant, quoi, en gros, c'est ça.
okay. So okay. That's emotional, because we're lazy, isn't it? Was it the gist of it? Yeah? Yeah? Okay. Or the rational? The rational, okay.
So is the rational the same? So doing... Ah d'accord, c'était rationnel, pardon. Ok. Et qui pourrait dire pourquoi il a voté pour émotionnel? C'est-à-dire, sur quoi ça se base de dire, voilà, je fais mes choix sur les émotions?
Okay, so emotion based. Okay. So yeah, there was another question. Yeah, someone. Yeah, brilliant.
Le choix, c'est en fonction des émotions par rapport à la personne à qui on s'adresse. Donc, on essaye de comprendre comment elle fonctionne et du coup, on va plus chercher dans ce que l'on ressent plutôt que le rationnel.
Okay. Thank you. Of course, there isn't a right or wrong answer, isn't it? Because sadly, if you had said that human behavior is utterly rational and mainly irrational, then I would have to say with him, why do we do this? There's absolutely nothing rational about that particular behavior, isn't it? It's completely emotional. Unless you rationalize that you're seeking the thrill, and this is an easy and sort of like quick way of getting a thrill. But humans is things like that they are completely irrational or they're not rational, and we've got that emotional component. So equally, can I ask anybody, what was the last sort of thing you bought? Not think about something not kind of small, but a big purchase. What was the last thing that you bought? Bit bigger than a book. No, not bigger. A bit more expensive, or a dishwasher. Which model did you get? Why did you get that one?
It was the best who fit with my kitchen.
Okay. So it was a properly rational decision, isn't it? Just so that you measure your kitchen, it's the right color and the right price. And did you look at reviews? Did you look at reviews from other people that have bought it?
Not really, because it was the moment to exchange the other one, which was too old.
Okay.
So I needed quite the same. So it was very practical and very simple.
Practical and very simple decision. Okay. Someone else can give an example of another thing? Thank you for your example.
Une voiture, a car.
Okay, which one did you get?
Un décapotable, pour me faire plaisir, uniquement.
Why that one? Why did you get that one?
C'est purement émotionnel, c'était pas du tout pratique, c'est juste pour se faire plaisir.
And I'm sure that you could absolutely rationalize why you got that one, but at the end...
Oui, mon mari a essayé de me rationaliser.
But at the end, we know that decision, has got that emotional component. That's sort of joy and pleasure, be seeing people to say, "Oh, nice car, she's got." Again, that component is that power, that drive is so important. So you could have decisions so practical and rational. So decision is good decision, or decision like yours, isn't it? But again, this just reflects that whilst we can use some element of rational approach, maybe that the emotional aspect is also crucial. And I think that we do forget that emotional aspect when we develop interventions in a clinical setting. We think that people will do it just because it's the right thing, and we forget that they're humans, and that human behavior has got those. Can you think of any behavior, or any emotion rather than behavior? Can you think of any emotion that you could attach to an intervention or an improvement intervention related to cannulas? And this one is not too bad, actually. I could show you much worse ones. But if you were thinking about an intervention that wanted to improve, what emotion would you be able to attach to that campaign or that approach or that intervention? If there is one that we can attach or approach. I'll put mine just to understand that.
Si des fois il y avait une infection derrière un cathé veineux périphérique, je prendrais le cas et je le présenterai aux équipes de manière à montrer le cas comme un exemple à ne pas suivre et à ne pas faire.
That sounds wonderful, but what emotion would you want to convey? What is the emotion to show that something shouldn't happen? That's perfectly, that's you're doing the right thing, but what is the emotion that you would want to convey?
On my side, I would say, if you were the patient, would you like to have this catheter?
Yeah. So that's sort of like empathy, isn't it? And compassion. So again, it's easy, but how often are we using that emotional bonding and attachment to link up with the uses of an intervention? I would say not frequently. I would say that we're still using and preparing and designing interventions and implementing them from a very rational sort of point of view. This is what it's doing, and we can communicate, we can sort of like plan, review, and get into this very sort of formal process. But I think that we do underuse the behavioral and emotional component. Question or time? No, question. Question? Or comment, yeah?
Thank you. So I'm just looking at that, and I really like what you're saying there, but again, we're looking at the catheter and an arm. We're not seeing a person. So even in that picture, I know we can't put the person, but Walter was saying it'd be great if the patients weren't there, in jest. Yeah. But again, we're seeing this as sort of detached from the patient and the person. So almost the emotion is then detached as well.
Yeah. I mean, the task-based clinical practice and sort of like a problem resolution, case management, all these sort of like this language that moves away humanity and humans and patients, and that's what we're into, humanization, isn't it? But again, what I'm trying to say is like it's so easy to miss the point of including a behavior bond and link in an intervention. So human says, okay, yeah, it makes sense. That's what I would like to do it, rather than maybe fear to authority. Anything, and we were talking about before, like penalties for the speed limit and coercion. I mean, that's just like a emotional and behavioral approach, isn't it? But again, just try to think about how can you nudge, to use language that's sort of trendy now, how can you nudge those emotional links between your interventions and the users? I may sort of skip that one. I may skip that one as well, because hand hygiene, I mean, we practice perfectly well, so we don't think that this is a problem, we can move on. Again, because this is a workshop, if you were thinking, okay, so I really came here thinking to have some help trying to start an innovation or an intervention, or trying to implement an innovation or intervention, it may be really useful that you think about, okay, so whatever I wanted to do, have I got an answer for all those components? And this is sort of just like a quick cheat sheet to kickstart your innovation or intervention. isn't it? And to implement it. Have you got an answer to all of that? If you had a problem that you wanted to solve, can you quickly say that about your implementation or your innovation? Yeah. Yeah.
Je disais, on le fait intuitivement. C'est vrai quand on bâtit une intervention et qu'on souhaite la mettre en place, on va essayer de se focaliser sur les personnes qui sont les plus importantes, qui sont en lien avec le sujet qu'on souhaite aborder, et puis le mettre en place à un moment qui soit propice, voilà, dans un lieu qui est... Voilà. Donc mais cela dit, on ne va pas jusqu'à l'écrire et le formaliser avec une méthodologie vraiment détaillée, comme ça peut être le cas dans le cadre de l'implementation science.
Yeah. I mean, I still find fascinating that many of our policies in our hospital or guidelines really don't tell you exactly who should be doing what and what the rest of people should be doing. So again, by being really, really clear and explicit about who should be in charge of a given in charge, I mean by performing or monitoring or evaluating a given intervention or the implementation of it, we are creating pockets of uncertainty, isn't it? So if I only say that, say, a nurse should be monitoring a cannula, what will a non-nurse do or think about it? And if they see something wrong, are we allowing them to say, I don't like the way the cannula is looking, because they haven't got a space where they can say, okay, so if any clinician sees any part of this process that is not right, they should be entitled to say, this is not right. But our guidelines, our policies are just focusing on, A does B, but what does the rest of the team do? So those pockets of uncertainty, because they're not explicit, they're easily removable, but we're just focusing on a portion of it. Of course, thinking about the who, you need to understand your audience, like Scala. You need to, who are we talking about when we say the clinician, the nurses? Who are the nurses? Who are the doctors? Which doctors? Which specialty? What training? What level? Which site? I mean, do we know the audience? And it's very interesting because this may be another set of skills that clinicians, particularly in IPC and AMS, we haven't really had, and they're not in our curriculum. We need to use qualitative approaches to find out who are we talking about. So then we can think about what they should be doing. And these are just a couple of papers from our group, one of them where we wanted to find out why is it that the cannula management, how we use peripheral vascular catheters in our center, it's a process that could be improved dramatically. And we found that people didn't really know who should be involved in that process. And within those people didn't know, the ones that were using cannulas, there were a really heterogeneous group. So all the other interventions that we had put out there, they thought about people using cannulas as one very homogeneous group, but they're not. So the behavior of people in A&E was very different to the behavior from people in palliative care. And again, we need to know who's using them. So you need to have qualitative approaches, and they're beautiful and really rewarding. And again, when you're thinking about your audiences, and this is a wonderful paper from Lindsay Grayson in Australia, thinking about how we need to tailor, and I'm delighted that the tailoring came in a different talk before. You need to tailor your messages and your narrative. Your story has to be tailored to the mindsets, the way that the different audiences think. So in his sort of paper about how to involve different professionals, the same kind of story, and this is about personality profiles, the same story was tailored to how doctors' personality was sort of thought to be, nurses and other officers. So again, you can see that whilst all the messages really say the same thing, they're unique to every audience. And this was really powerful about this paper. And we're using these to include, for example, nurses in appropriate use of antibiotics and creating scripts that they can use with other professionals. Now, if you think about, what would you like to do, we also need to be mindful about has the audience got the capability of doing what we want them to do? And for example, when we were complaining in a way about the small participation of nurses in appropriate use of antibiotics, then it became really clear once we finished this study about why that may be happening. And in this study, we approached all the universities in the UK for doctors, pharmacists, nurses, veterinary doctors and dentists, everybody who uses antibiotics. And we wanted to know what skills, knowledge and training they were getting in university. So you can see that nurses at the bottom, they really were getting very little education about some of the key steps in appropriate use of antibiotics. So of course, when these poorly trained nurses in this area got into clinical practice, of course they were performing to the best of their abilities, but those were not enough to perform at the level that we wanted them, or we expected them, or we needed them to be. So again, if people don't have the skills, they may not be able to do what you want them to do. So then you have to, influence, for example, national education policy. So we're quite lucky that we've been able to do that. And from next January, all nurses in the UK will have a specific module about antimicrobial stewardship. So when they get to be a qualified nurse, then we can say, well, you've had the training, so now really your performance should be better. But then I know that at the beginning of the talk I said education wasn't everything, but this is just an example of we identified a gap and we solved the gap, so then people can perform at the level. Does that make sense? Yeah. Of course, you need to be having a look and analysing what may be influencing the behaviour, the performance and the practice of people. And I think that, again, we've touched upon really quickly about the motivational aspect, the human aspect. What may make people to feel in a particular way about a situation? And again, when we wanted to see why are nurses not being involved in antimicrobial stewardship, it's very interesting to learn that they may not think, your colleagues may not think that this is an area where they need to be involved. So it may not be about knowledge at all anymore. It may be that they say, well, this is not for me. Why do you want me to get into this arena when this is not my area of practice? And maybe think about now, is this something that may be happening now? You as an IPC nurse practitioner, when you read or see all these ideas flying around about you should be getting into antimicrobial stewardship, you should be doing more about how antibiotics are used in your hospital. What do you think about it? Are you motivated to do it? Do you think that you should be doing it? Oh, yeah, sorry. And we got another poll here. Sorry.
Donc, vote, voilà, c'est principalement pour les infirmiers et infirmières, mais pensez-vous que vous devez participer au bon usage des antibiotiques? Donc c'est la particularité d'Enrique, c'est qu'il est infirmier et il participe au bon usage des antibiotiques, ce qui est vraiment en plein développement à la fois en Angleterre mais aussi aux États-Unis. Voilà. Donc l'idée c'était de voir votre point de vue sur ce sujet-là. Donc je lance le vote. C'est parti. Voilà la réponse.
Oh my God. Okay, this is really cool, isn't it? So wow, so these results. This is completely unexpected. This hasn't really, this is unique. This is exciting. This is cool. So okay, so you infection prevention and control experts and people think you should do antimicrobial stewardship. That's we have got no work to do then here. That's great. Okay. And finally, just to sort of sum up, when you think about an intervention, an innovation, the implementation of it, you need to really think about how have they got the opportunity to do what we are telling them to do. And for example, this is another piece of research when we wanted to see if nurses do antimicrobial stewardship across Africa. So we first had sent this survey to nurses around the continent and said, do you do antimicrobial stewardship? And only 30% of them said that they did. But then when we actually broke down the different little tasks about included in antimicrobial stewardship in appropriate use of antibiotic, you can see how there's a massive range of activities that professionals told us that they were doing. And I think that that is important because it just reflects that some of them required to have the opportunity, the motivation to sort of say, to remind the prescribers about antimicrobials, whether they were right or wrong, or the need to review daily. So if we were to just sort of leave it and say to people, do you do antimicrobial stewardship that we said to you, and you had said, no, we don't really do, we don't really think we should do, I think that then we need to sort of be a bit more elegant and a bit more precise and think about, but what is it that people do? Have they got motivation and capability and opportunity to do more? It may be that in some African countries, it may be that in some European countries, people cannot do more because there isn't the scope or the possibility to do more. And in other countries, it may be that there is a scope to do much more. So again, we need to think about motivation, capability, motivation, and opportunity. Identify the competition. 5 minutes, yeah. Identify the competition. So could it be that your intervention is not being implemented because there are bigger forces that are preventing it from happening? Could it be that other professional groups are doing something very similar? Are doing something that could be opposing? Is it something that could be possible in France? It certainly happens in Spain. That professional groups have got agendas and priorities and motivations. So again, are we putting the target audience of our intervention in a position where they would love to do it, they've got the skills to do it, they've got the opportunity to do it, but there are bigger forces that prevent them from doing it? Yeah.
For infection control and antibiotic stewardship, there is strong boundaries because infection control is one specialty, AMS is another one. AMS is the ID doctor's part. And the other thing, I think, when you take one specialty, if you take AMS, you will also have responsibility part of doctor and nurses, and if you take IPC, you will have cares with nurses, more micro with doctors. So there is boundaries. Yes, it's the case in France.
Yeah. So again, this links with this the bigger picture, the macro determinants that Rahila was talking before, isn't it? Our interventions are not in a vacuum. The implementation doesn't happen in a vacuum. Even if we're targeting one group, we need to think about what is happening around that group. This is just some examples from the wonderful Susan Mickey model that you can see all the different options that you can put in place if you are thinking about designing an intervention and implementing that intervention. Anything from using communications to use rules, increase understanding, use policies, not just positive, negative. So as you'll get the slides, you can see that there are, and of course as has been mentioned in the morning, you've got loads and loads of approaches and techniques that you can use to tailor what you want to do to the people that you would like to work with. And this is my final slide. I do think that it's easier than you think. I do think that this sort of implementation process and behavior change process is sort of very similar to sort of like not ride an elephant, sort of like allow an elephant to carry you from one place to the other. You just need to give clear direction to make sure that the elephant knows where it's going, even if they really just take you where they want. Motivate the elephant, so we need to find what emotionally it's going to allow the elephant to take you where they want to take you, and then you need to reduce the obstacles, shape the path, make sure that the environment is actually conducive to go to where you want to go, and to make the journey really, really smooth. But I do think it's easier than you think. So thank you ever so much for your time. I hope it's been a little bit useful. Thank you.